Hello and welcome to our webinar, Mapping the Child Health System at a Local Level to Reduce Health Inequalities. And this is a phase 1 project from the Children and Young People's Programme of the NIHR School for Public Health Research. And the study team involved in the project, we had Ruth Kipping, Tricia Jessamine, Joe Williams and Pippa Williams, all from the University of Bristol, Mary Crowder, Hannah Fairbrother and Katie Powell from the University of Sheffield. And today, presenting to you, we have Tricia Jessamine, Mary Crowder and me, Hannah Fairbrother. So just to give you a short overview of our presentation today, we'll take you firstly through the study background and the rationale for our project. Then Mary will take you through a brief overview of the different methods that we employed. And then Tricia will explain and describe our systems map that we created for the project, bring together the conclusions from the project and signpost you to further information. So, the background to the study and our rationale. Children and young people's health in the UK is in crisis, with worse outcomes than in many similar Western countries and increasing inequalities between children and young people from the least and most deprived areas of the UK. The situation is exemplified by the infant mortality rate, IMR, one of the most important indicators of overall population health, which had been improving steadily in the UK up to 2014, but which has since stagnated. And in England, the IMR has increased. This stagnation has not been seen in comparable European countries, and the UK now has one of the worst IMRs in Europe. Highlighting the rising inequalities, an analysis of the increase in IMR in England from 2014 to 2017 found that it disproportionately affected the poorest areas of the country, while many affluent areas saw the IMR unaffected. The trend is echoed across many health outcomes for children and young people, including mental health, obesity, and oral health. Child health outcomes also vary across ethnicity, with children and young people from Black and minority ethnic groups consistently at a disadvantage. These inequalities are persistent and increasing. Despite this, essential services for child health are being cut, with disadvantaged areas often seeing the steepest cuts. The health and social care reforms in 2013 transferred responsibility for public health services to local government authorities and presented an opportunity for them to align the commissioning of preventative health services, for example, health visiting, with their existing responsibilities, including spatial planning, licensing, environmental health, early years education provision, and early intervention work with children and young people and families. However, emerging evidence suggests that while some alignment of public health priorities is being achieved at a local authority level, commissioning and decision-making relating to the health of children and young people has become increasingly fragmented. Such a landscape is particularly challenging when seeking to improve and reduce inequalities in children and young people's health. Health inequalities are complex. They're created, maintained, and exacerbated through multiple interrelated pathways. One way to understand and work with this complexity and address the fragmentation of child health policy and practice is to apply a systems-based approach to identifying the determinants of child health inequalities at a local level. Perhaps the most familiar example of systems thinking is the foresight map shown here, which aims to depict the determinants of obesity. Systems thinking has emerged as a promising approach to addressing complex public health issues in recent years. It conceptualizes poor health and health inequalities as outcomes of a multitude of interdependent elements within a connected whole system. Systems thinking encourages the consideration of how different actors, individuals, populations, or organizations relate to one another and how activities in one part of a system may affect another. Within public health, systems thinking has often been applied through taking a whole systems approach. Conceptualized in a recent systematic review as considering the multifactorial drivers of public health or the social determinants of health that also involve transformative coordinated action, including policies, strategies, practices across a broad range of disciplines and stakeholders, including partners outside traditional health sectors. One tool to aid systems thinking is the systems map, as seen here with the foresight map, which has facilitated systems thinking and hypotheses of solutions to rising obesity trends, which range from individual behaviour change through to population policy approaches. Indeed, the majority of published studies using systems approaches to address child health have focused on healthy eating and obesity, with a paucity of studies relating to other child health outcomes. Our study seeks to extend the scope of a systems mapping approach beyond single child health outcomes to address inequalities in child health more broadly. The overall aim of the current study was to scope and create a child health system map for use at a local level in order to inform opportunities for effective interventions at systems level to reduce child health inequalities.
Thank you, Hannah. So a quick overview of methods. The methods we adopted had two main stages. The first stage involved the development of area-specific child health system maps in two contrasting areas. And in the second stage, we drew on these two local maps to inform the development of a generic system map of local determinants of child health inequalities that is not area-specific. So first of all, I'll take you through the methods for the local area-specific maps, their development. To develop these maps, we worked in two contrasting local authority areas. Site 1 was a city in the north of England, Site 2 a rural county in the southwest. Site 1 is a unitary authority, Site 2 is a two-tier authority. The two sites also differ in terms of levels of deprivation and their different demographics. So Site 1 is ranked higher in the indices of multiple deprivation for local authorities than Site 2, and Site 1 has a higher proportion of Black and ethnic minority residents compared with Site 2. The scope of the map was based on local authority area, but was not intended to be just for local authorities. Our aim was to develop a systems map of interest more widely to all stakeholders with a role in children and young people's health. Approval for participation in the study was granted by the local authority director of public health in each area and with senior staff in the clinical commissioning group for each area. Once approval was obtained, we worked with our contacts in each site to identify key people and opportunities to engage with for fieldwork and data collection. So the fieldwork in each area involved a number of different activities. Firstly, we conducted qualitative interviews with senior decision makers with responsibility for child health. These interviews covered the local context, key challenges, local priorities, and recent key initiatives in relation to child health outcomes and inequalities for children and young people aged 0 to 25. We also asked interviews about their experiences of whole systems approaches to child health, both generally and specifically in their local area. The next stage of the fieldwork was to hold a series of group concept mapping workshops in each site with different stakeholder groups. We held separate workshops with professional staff with responsibility and expertise in child health. This included representatives of the local authority, the NHS and clinical commissioning group, third sector organisations and elected members. We held workshops also with children and young people from the local area and with parents and carers of children and young people. The next slide provides a bit more detail about these mapping workshops. So we got the group together and we asked participants to consider the two questions you see here. What factors drive child health and well-being in the local area, and what factors drive health inequalities between different groups of children and young people in the local area. When we work with children and young people, we also included an additional warm-up question to get them thinking about what good health and well-being means to them. So in each of the workshops, we started by asking participants to generate factors. This involved individual brainstorming to generate statements in response to the questions and to write these on cards. Then in small groups, participants took turns to share their factors by putting them on the table and explaining why they felt the factor is important and how they feel it impacts on child health and child health inequalities. As more factors were shared, the group were encouraged to cluster similar factors together and talk about any links between the different factors. Throughout the workshops, we used note takers and audio recording to capture these narratives, and at the end we collected all the factor cards and took them away to contribute to the analysis. So if we just move to the previous slide. So following the workshop, we moved on to the initial development of the area-specific maps. In each site, we analysed factors, notes and transcripts from the various local workshops. This involved removing duplicates, consolidating factors and drawing links based on the discussions that we'd heard in the workshops. This process was informed and augmented with data from the earlier qualitative interviews with the senior decision makers. We conducted a thematic analysis of the factor lists with their associated narratives and links, again to further consolidate factors and to cluster them into meaningful subsystems or domains. We then used mapping software called View to draw factors or nodes with links between drawn where indicated by the data analysis. And at the end of this process, we had our initial area-specific maps representing the child health systems of the two contrasting local areas. So the next stage of the field work was validation. The initial local specific maps were presented back to professional staff in each of the sites for refinement and validation. And finally, we held a series of utilisation interviews in which we explored the potential utility of maps with professionals who'd been involved in those local workshops. So moving on to the methods for the development of the generic system map, we brought together the two area-specific system maps and compared and contrasted those to determine commonalities and contrasts between factors. The aim of this was to remove any area-specific factors and combine the remaining factors to develop a more generic version of the child health system map that could be applied to any English local authority area. Once the final list of factors had been agreed, links were added from the area-specific maps, and again an initial visual of the generic map was produced in the View software. We then ran an online survey to share the initial version of the generic map with national experts in child health, health inequalities and systems mapping to get their input to help refine and finalise the map. The survey went out to experts in child health, health inequalities and systems mapping from academia, to national leaders and decision makers in child health from Public Health England, the Department of Health, the NHS, the local government association and leading children's charities, and to local policy makers, commissioners and practice collaborators, including directors of public health and practice collaborators working in child health settings. We ran 2 rounds of the survey. In the first round, respondents were asked to comment on the map and suggest changes, for example, if they felt factors were incorrect or in the wrong cluster or domain, or if there were factors that were missing entirely. We refined the maps based on the results of this first round, and in the second round of the survey, respondents were asked to comment on the revised map and the changes made in response to the feedback we'd received, and also on to comment on their potential utility of the map as they saw it. And the final data collection method we used was further qualitative interviews with some of the senior staff who'd been involved in the map development processes locally and some of the participants from the online survey. These interviews explored the potential utility or not of the generic system map in supporting policy intervention design and/or practice, and barriers and facilitators to using systems approaches to address problems in child health and inequalities. So that was the methods. I'll now pass you on to Tricia, who will talk you through the generic system map that we produced.
Thank you, Mary. Because of the scope of the map, we had over 100 individual factors, and we needed to find a way to present these in a way that made sense. After a review of the literature for existing frameworks of child health and child health inequality, we used and adapted a framework developed by Sharon Goldfelt and colleagues from the Kids and Community study and arranged the factors on our map into 6 separate domains. And these 6 domains are local services, governance, economics, the physical environment, the social domain, and the personal domain. On our map, every factor is grouped into one of these 6 domains, which are colour-coded on the map, and the domains can also be looked at in isolation to break things down. This is the whole map. I know it's not very readable in this presentation format, but if you are able to look at a high-resolution PDF online, you can zoom in and see it much more clearly and see the detail. This next slide does that slightly, and what I wanted to show you before I talk through the 6 domains separately is that connections between each factor on the map cross domains. So factors in the social domain, the orange circles on the map, are connected to factors in the economic domain in purple and physical domain in yellow, for example. You can lose this sense of interconnectedness between factors and domains as you examine it domain by domain, as I'm about to do. So I just wanted to emphasize that point. The service domain comprises 46 factors and represents the availability and delivery of services provided by the public, private, and third sectors at the local area level, all of which impact on child health outcomes. There is a cluster of factors in the middle that influence the quality, quantity, accessibility, and coordination of all these services. The 3 factors with most links to those in other domains are, unsurprisingly, health, social care, and education. We have represented health services by only 3 separate factors on our map: primary, secondary and tertiary, and public health, rather than listing all the specific health services. And this is partly to keep the number of factors down, but also because it makes applicability of this map to any local area much easier. The range of service types emerging from the workshops was much wider than that, though, indicating the wide array of service provision in the local area perceived to impact on child health outcomes and inequality of outcomes. They include the police, housing, libraries, arts and culture, and access to and quality of all of these have an impact on child health inequalities. The economic domain comprises 12 factors associated with the economic resources available to children and young people at both the household and local area level. We know about the associations between household income and area deprivation with child health inequalities, and so those 2 factors in the economic domain have the most links to factors in other domains, particularly health behaviours and outcomes in the personal domain. Household income is linked with parental employment status, but these 2 are themselves influenced by area-level factors, including employment opportunities and conditions. Local authority capacity to generate income relates to the powers that local authorities have to raise additional revenue beyond national government grants. National funding grants are considered outside the boundaries of this system, given the limited capacity for change or influence at the local area level. Local authority capacity to generate income will include things that local authorities can do to raise revenue, including the adult social care levy on council tax, the community infrastructure levy, rents, fees, and other kinds of charges. The governance domain is about the effective development and implementation of policy to support child health and reduce inequalities at the local level. Participants identified that local governance and leadership will be influenced again by factors outside the boundaries of the local system, in particular by policy and statutory requirements set by national government. But there are key factors within local influence, and these will include prioritisation of child health, allocation of spend, leadership and accountability for child health, cooperation and alignment across various local agencies, good information sharing, and the engagement of children and young people themselves in local governance. This domain is about the physical environment in which children and young people live. It's broadly split across safe places for social activity, housing, transport and physical infrastructure, and local amenities. Safety emerges as a key quality for many factors in this domain, and what is safe will differ across subpopulations of young people, for example, young people of different ages or children with disabilities. It includes things like local access for play, social and physical activity, green space, arts, and cultural and religious activities. Also on there, you'll see accessible public transport and active travel routes, secure quality homes and residential area design that supports a clean, safe living environment. And finally, there are factors concerned with local amenities and the availability of healthy and unhealthy consumables, including healthy food, fast food, alcohol and tobacco. Factors in the social domain are related to the people around children who influence their health behaviours and outcomes. These again split broadly across parents and families, peer groups and local communities. The domain also includes the influences of people that children encounter online and in the media, including social media. Key factors in this domain, and by those I mean ones with most links to health behaviours and outcomes, are mostly those linked to family and parental support. But the map does also show the influence of peers and communities and includes things like community cohesion, social capital, and local rates of crime and disorder, and the influence of these on children and young people's health. The personal domain was added to the Goldfelt model to capture the factors emerging for workshops that referred to children and young people's behaviours and outcomes. The factors shown here are shown independently without links, because interestingly, although they are interrelated, most of the links identified by participants were to factors in the other 5 domains. Some factors in this domain are health outcomes. For example, you'll see mental health on there. Some are behavioural outcomes with implications for health, for example, diet and alcohol use. Other outcome types are developmental or educational, for example, achievement, employability, speech and language skill, reflecting the known links between these and later life health inequalities. 2 further clusters of factors emerged during the analysis of local site data that were considered important determinants of inequitable health outcomes by participants, but not amenable to local influence and therefore outside the boundaries of the system. The first cluster generally refers to the wider national and global determinants of child health inequalities. It includes things like climate change, national government policies, in particular those related to austerity and welfare reform and cuts to local government grants. And these are not amenable to change at the local level, but we know that they have a huge influence on the local context. So these are listed alongside the map itself. The second emerging cluster are subpopulations of children and young people defined by their personal characteristics or circumstances, which again are not amenable to local influence, for example, gender, ethnicity, children in state care, but which may heighten their risk of poor health and well-being outcomes. We consulted with the participants present at the validation and feedback workshops in each local site on how best to represent these groups. They suggested that the map should be viewed through an inequality lens according to these different population groups of children and young people. As an example, safe areas to play and socialise will look very different for children with a disability. Service accessibility will vary across gender, ethnicity, and groups such as looked after children or those with intellectual disabilities. So having these groups listed alongside the map is intended to encourage users to consider how the system works or doesn't work for these high-risk groups. So here is the full map again, showing the 6 domains, how all the factors interrelate, and alongside the influence of factors outside the system and the subpopulations that may be at heightened risk of poor health outcomes. So what can we conclude from this? The first thing is that mapping the determinants of child health inequalities for all populations of children and young people aged 0 to 25 and for all health outcomes, not just single issues like obesity, is possible, and that wasn't obvious at the start of this project. Most of the systems work to date has been around obesity or other single health outcomes, and the idea of looking at health inequality in the round seemed ambitious. But the fact that local community stakeholders, including children and young people themselves, their carers, and staff at a range of levels across organisations in the public, private and voluntary sector, the fact that they engage with this work and engage with the group concept mapping approach suggests that people agree that there is a local child health system and a system that contributes to a whole gamut of inequitable outcomes. This was further supported by the response we had to the online survey, where colleagues really engaged in the detail of the map, rather than questioning whether trying to draw a system map of this scope was a reasonable thing to do. So we achieved very good engagement with systems thinking to address the inequalities of all health outcomes, recognising that there is value in considering health inequalities in the round at the local level. However, as a result of that scope, the map is complex, it's messy, and we know that we may have to think about a more interactive version that can be more easily adapted and explored if local areas are going to make use of it. It's also qualitative, so the links between the factors have no indication of the direction of influence or strength. So this is not a model that you can plug in data and figures into and predict outcomes, but it's not intended to be an accurate representation of an objective, observable system, but rather an accurate representation of the system that influences child health inequalities at the local level, as understood by the expert participants involved in our study. Finally, all this was done pre-COVID. The impact of COVID on the public health landscape in the UK is not yet fully understood, but I think we know that in the long term, child health inequalities will likely be exacerbated for several reasons. Increased rates of financial instability will likely lead to a rise in child poverty in the UK. And the heightened impact of COVID-19 on those living in more deprived areas and those in Black, Asian and minority ethnic groups means that children from these groups will be more likely to have been bereaved or see their family income level drop. And the pandemic has been described as a systemic shock to the determinants of child health, and the immediate response to it has diverted resources away from child health and social care, including acute services for life-threatening illness, child protection services, and preventative services that support early years development. It may not be all bad. As we emerge from the immediate, it may be an opportune time for local areas faced with extremely stretched resources to think again about how services for children and young people are delivered and health inequalities addressed. As local areas adjust to the new normal, they may also reorganise service delivery to better support child health. So we have tried to suggest a number of ways in which our map may be useful to that. First and foremost, we hope that the map is helpful in demonstrating to stakeholders the importance of policies that tackle the systemic drivers of child health inequalities, beyond those most traditionally associated with public health. We hope it helps understand how the local system operates to produce inequalities and identifies potential points to intervene that may close the gaps, making the most of limited resources. Intervening in the local system may be in the form of a policy or an intervention, but mapping the whole system also demonstrates how single programmes, policies and interventions are unlikely to impact on the complex and dynamic issue of child health inequalities. It is our hope that the map helps demonstrate that for child inequalities to be successfully addressed, coordinated action across a range of local authority, third sector, health and community groups is required. For further information on this work, the full report, the map itself, and other publications will all be available or signposted on the NIHR School for Public Health Research website. You can also email the research team, and our contact details are on the current slide. We'd be very happy to hear from you.